So there are different modes. One of the modes is called volume control, and the control word means you're setting that number to not change. You are controlling the number. So you can have a volume control mode. You can have an assist control mode where the machine is actually doing all the work. But if the patient breathes higher than the number that you have set that the air should be delivered, the machine will give all the air to that patient. And there's something else called a pressure control where the air goes in, but it goes in only to the pressure that you have set it. So the pressure gauge will say, okay, air is coming into the lungs. They're measuring the pressure. You've set a pressure number of 25. Anytime it starts going beyond 25, the airflow is cut off. There are other modes, including synchronized intermittent mandatory ventilation or SIMV, where essentially the machine is giving air to the patient whenever he wants it. But in addition to that, there will be some mandatory ventilation where you will set a rate of say 10, and 10 breaths will be given for sure whether the patient breathes or not. Then there's the concept of CPAP, which is continuous positive airway pressure, where you deliver air pressure into the lungs at a certain set pressure to make it easy for the patient to breathe. And we'll talk about how does the machine know when the patient wants a breath. So the machine can say, okay, the doctor has set the numbers to be say 10, which means every few seconds for a minute, 10 times the breath will come out. Suppose you set it for 12. Every 10 seconds, you're going to get, every 5 seconds, you're going to get a breath. For 12 times 5 is 60. So every 5 seconds, you'll get a breath. Suppose somebody has set the rate as a different rate. If it is high, the number of breaths will be higher. The problem is that suppose the patient wants to be the 20 and you have set the machine only at 10, the patient may have difficulty because 10 of those breaths, he has to make an effort to get the air. And those are the concepts of trigger, as well as the situation where you're getting a machine to understand that the patient wants a breath will happen. And this actually is very high tech in the sense that there are pressure gauges in these ventilators, in the pipes. And these pressure gauges are measuring the pressure. So when you take a breath in, and in your ventilator, for example, when you do a suck the air in, the pressure drops a bit and the machine knows somebody is asking for a breath, but it is checking that number several hundred times in a minute. It's actually checking it several hundred times in a minute, and then it is ready to give the breath to the patient. You could also have a situation where you want to take a really deep breath, and then the machine can also give you a deeper breath. And we'll go through these again, so don't get too worried about these concepts. And again, there's an introduction to the whole system, and many of the terms are new, but the next time you're at the bedside, many of these things will make sense to you. So the initial settings of a ventilator, which we'll see in the video, include the tidal volume, the rate, and the concept of PEEP we have not gone over yet. How much oxygen that you want the patient. We talked about the mode. There, of course, the concept of the alarms we'll talk about. And then there's a concept of the inspiratory-expiratory ratio, where you need to see how much air goes in at what rate, and you decide what is the speed of it. Let's quickly go through this concept here. Suppose you have somebody breathing at 20 times a minute. 1 minute has 60 seconds. So in your mind, patient breathing 20 times in 1 minute, which means each breath is about 3 seconds. So in those 3 seconds, you can have like a 1 second inhalation, 2 seconds exhalation. So that is a 1:2 ratio. But you can change that. You can make the air get in faster. So you can make it 1:3, where out of those 3 seconds, you give more time for the air to go out. And that can be important in somebody whose carbon dioxide is high, where you want to ensure the carbon dioxide actually comes out for a longer duration of time. When you adjust the ventilator, you can use a blood gas. You can use a concept of a PEEP, FiO2 ratio. And you can also, and we'll do the review at the video of the initial settings. And of course, we talked about the trigger. The trigger can be pressure related or flow related. And the pressure is when you take a deep breath in, the pressure drops and the machine knows to send the breath in. It can also be related to the flow, where there's a flow meter that's measuring the flow. When you suck the air in, the flow suddenly drops, and then you end up needing to give the machine knows to give breath. And these are all electronically controlled, and many times you have little valves in the tubes which open and close rapidly based on the pressure settings. I'll quickly touch on the concept of PEEP, and then we'll move on to the video. So PEEP is essentially where you're blowing the lung. Remember the balloon example? We blew the balloon open. Once you blow the balloon open, you have to keep the balloon inflated. In order to keep the balloon inflated, you have to continue to keep pushing air in. And that is where it is called positive end expiratory pressure. Inhalation, exhalation, but you don't want the lung to fully collapse. You don't want the balloon to collapse. In order to ensure that, you have to continue to keep giving a little bit of air in. And that is the concept of the positive end expiratory pressure, or PEEP. And PEEP is a vital component of oxygenating the lung. When you saw that picture I showed you of the alveolus with things inside it, because there's so much water and inflammatory material, it's very difficult for the air to go across. In addition, you might remember the lungs have surfactant. Surfactant is essentially something that prevents the air passage and the alveolus rather from collapsing. And when you have ARDS, these are all impacted, and you have to give pressure from outside to avoid the pipe and the alveolus from collapsing down. And that is what is the concept of PEEP. Somebody asked briefly, what is plateau pressure again? Briefly, we'll go over this again, but the concept is, it is a measurement of the pressure inside the alveolus. It is a pressure that is being seen by the alveolus in order to make sure that that number doesn't exceed 30. The lower the better, to make sure that you're actually not damaging the lung, because there is a concept of barotrauma where the lung can collapse when you give too much pressure. There's also a concept of volutrauma where the lung is expanded too much and that can cause damage. There's also another concept called atelectotrauma where the lung opens, closes, opens, closes, opens, closes, and they've done electron microscopically, they've seen that there are cuts in the lung which happen because of this. So these concepts are also very important when you're ventilating somebody with ARDS. So I'm going to have Girish, are you online? Okay, so see, what we're going to talk about is the usage of ventilators and the other options. We also will talk about non-invasive ventilators. Now, non-invasive ventilators involve using a mask on the face to deliver airflow. You can also have an invasive ventilator connected to the airway by an endotracheal tube. So you have the ventilator tube, or it can be a mask on the face. In COVID-19, they recommend that you don't use non-invasive ventilation, mainly because it's the risk of aerosolizing all the viral particles. Some people who are on a ventilator for a long time may need a tracheostomy, which is a hole in the neck, and the tracheostomy is connected to a ventilator. There are many people who have shown that high flow oxygen, very high flow oxygen can also help you, but the same risk of infection may be there. And when you have an invasive ventilator, you can have oxygen coming in. You can also have regular air coming in, so that you can mix and match and decrease the oxygen saturation or increase the oxygen percentage as much as you need it. Now, many patients need to be paralyzed or need sedation when they're on a ventilator with ARDS. That's because every time you try to make an effort to breathe, it is a lot of energy expenditure on your part. In addition, it's a lot of effort to fight the ventilator, and that can lead to damage to the lung. And patient-ventilator dyssynchrony, which means patient and ventilator are not playing together, that can cause a lot of problems. There's also the issue of infection in the lungs that can happen, as well as pneumonia. So you need to keep the head of the bed elevated to avoid VAP. VAP is ventilator-associated pneumonia. So all the pipes and tubes that are connecting to the ventilator should not be changed unless they're extremely blocked or solid. And when you're on a ventilator, inline suctioning is recommended for safety, meaning you don't keep disconnecting, because every time you disconnect and you have somebody whose air patch is distended, you have pressure inside. But if you disconnect it, the pressure drops, the lung can collapse. That can be very difficult to bring it back up. And if you're not able to bring it back up soon, your oxygen level can drop.